I'd like to thank the program committee for giving me the opportunity today to discuss heterogeneity in treatment outcomes for HER2-positive breast cancer with a focus on clinical management strategies. Listed here are my disclosures. When thinking about how to target HER2 heterogeneity, I thought it would be important to focus on three specific areas. One would be to think about how to develop therapeutic strategies specifically for hormone receptor positive HER2-positive disease. The next would be to think about overcoming intratumoral HER2 heterogeneity, and then finally, to think about optimal approaches for low HER2 expressing breast cancers. So we'll start off with the first area with the focus on hormone receptor positive HER2 positive disease. We know that approximately 50% of HER2 positive breast cancers are in fact hormone receptor positive. There's been some concern that hormone receptor positive tumors that are also HER2 positive are relatively resistant to endocrine therapy in both the early and advanced stage settings when compared to HER2 negative disease. Studies have suggested that activation of HER2 can induce resistance to endocrine therapy by directly phosphorylating and activating ER. And given this potential for HER2 and ER bidirectional crosstalk, there's been a lot of interest in thinking about combination strategies that target both of these pathways concurrently. We've seen some data to suggest that hormone receptor positive, HER2 positive cancers may have relative resistance to endocrine therapy. This study investigated the effects of HER2 on response to endocrine treatment amongst patients with metastatic disease and found lower response rates and shorter time to progression amongst patients with hormone receptor positive, HER2 positive tumors compared to those that were hormone receptor positive and HER2 negative, suggesting that HER2 positive tumors are less responsive to hormonal therapy in the absence of HER2-directed treatment. Because of this, there's been an interest in trying to add HER2-directed therapy to the endocrine backbone. The TANDEM study, as shown in the figure to the far left, randomized patients with hormone receptor positive, HER2 positive breast cancers to receive anastrozole alone or in combination with trastuzumab as first-line therapy and found an improvement in objective response and a 2.4-month improvement in progression-free survival, but no difference in overall survival. We've also seen studies that have looked at adding lapatinib to endocrine therapy, either with an AI, as seen in the middle figure, or with fulvestrant, as seen in the figure to the far right, with these studies suggesting improvement also in progression-free survival, but not in terms of overall survival. Given these improvements with the combination of endocrine therapy and HER2-directed therapy, we've now seen data from a trial looking to see if endocrine therapy and HER2-directed therapy can substitute for chemotherapy and HER2-directed therapy. And we saw these data at ASCO earlier this year from the SYS-UCC study. This trial had randomized patients to receive endocrine treatment with trastuzumab or chemotherapy with trastuzumab and found no difference in terms of progression-free or overall survival. I would, however, interpret these data with caution and would not take it to suggest that we can simply substitute chemotherapy and trastuzumab with endocrine therapy and trastuzumab for all of our hormone receptor positive, HER2 positive patients. We have to recognize that this trial did not use the standard of care treatment at this current era, which does involve dual HER2-directed therapy with trastuzumab and pertuzumab in the first-line setting. We also saw that overall survival did not seem as long as it was in the Cleopatra study. And so I think because of this, I would think about endocrine therapy and HER2-directed therapy in those patients who may have contraindications to chemotherapy and trastuzumab. There is, however, data that has looked at endocrine therapy with dual HER2-directed therapy. We saw data from the PERTAIN trial, which had looked at adding pertuzumab to the combination of endocrine therapy and trastuzumab, and found that the addition of pertuzumab resulted in a 3-month improvement in progression-free survival. We also have seen data from the alternative study that looked at dual HER2-directed therapy with lapatinib and trastuzumab in combination with an AI, and found that this triplet strategy performed better than the doublet of either an AI and trastuzumab or an AI and lapatinib, again confirming that dual HER2-directed therapy is better than just one HER2-directed agent with endocrine treatment. So while we have some strategies to think about treatment for hormone receptor positive, HER2 positive disease, it's important to also think about outcomes for this subset of breast cancer. When you look at outcomes in the preoperative setting, you can see consistently across neoadjuvant trials that have utilized HER2 targeted strategies that PCR rates are lower in hormone receptor positive disease compared to hormone receptor negative disease. That said, data from large adjuvant studies has shown that trastuzumab works for both hormone receptor positive and HER2 negative disease, with hazard ratios associated with trastuzumab use similar regardless of hormone receptor status. Interestingly, though, when you look at long-term outcomes in terms of disease-free or event-free survival, these outcomes are similar for hormone receptor positive patients, with a trend to doing slightly better than their hormone receptor negative counterparts. When you specifically look at outcomes over time, you can see that patients who have hormone receptor negative disease tend to have a shorter time to event, particularly within the first 5 years, than those patients who have hormone receptor positive tumors. So the cumulative hazard for relapse-free survival is lower in hormone receptor positive, HER2 positive patients within the first 5 years. But then between years 5 and 10, in fact, there is no difference based on hormone receptor status. When looking at benefits of treatment in the metastatic setting, we can see, generally speaking, hormone receptor negative breast cancers tend to have higher relative benefit from HER2-directed therapies, specifically when looking at TKIs, monoclonal antibodies, and TDM1. This, however, is in contrast to data we've seen in the early stage setting from the Extenet trial, where patients who had hormone receptor positive disease seemed to do better from extended treatment with neratinib than those patients with hormone receptor negative disease. You see the hazard ratio for invasive disease-free survival for hormone receptor positive tumors was 0.6 compared to 0.95 for hormone receptor negative disease. And while TDM1 seemed to have larger benefits in the hormone receptor negative patients in the metastatic setting, when we look at the recently presented data for TDXD in the DESTINY-Breast03 study, we see in fact similar benefits for TDXD in hormone receptor positive and hormone receptor negative disease, suggesting that these differences in outcome may be different dependent on the agent that you're looking at. And so while we've seen these differences in outcomes by various treatment strategies, what about novel treatment strategies for hormone receptor positive, HER2 positive disease? One potential strategy would be to use agents that have been found to be beneficial in hormone receptor positive, HER2 negative disease, such as CDK4/6 inhibitors. We do have preclinical data that has suggested that CDK4/6 inhibition does not just work in luminal ER positive disease, but in fact, HER2 positive cell lines have similar sensitivity. And we now have clinical data in the metastatic setting, specifically from the MONARCH-HER study, that found that the triplet combination of fulvestrant, abemaciclib, and trastuzumab resulted in higher objective response rates and longer progression-free survival when compared to chemotherapy and trastuzumab. There are now ongoing registration studies looking at the use of CDK4/6 inhibition in the early stage setting as well as the metastatic setting. The MONARCH-HER study is looking at the use of abemaciclib and endocrine therapy, comparing it to placebo and endocrine therapy in patients who have high-risk hormone receptor positive, HER2 positive disease that have completed their HER2-directed therapy. This study is currently enrolling. Additionally, the PATINA study, which has completed enrollment, had randomized patients in the metastatic setting who had completed their first-line therapy with chemotherapy and dual HER2-directed therapy, and then gone on to the maintenance setting with their endocrine agent, and then got randomized to receive that with or without the CDK4/6 inhibitor palbociclib. And so we are eagerly awaiting data from this study. So what about the road ahead for hormone receptor positive, HER2 positive tumors? I think we're going to need to learn how to optimally combine endocrine therapy with HER2-directed therapies. And so now we will have new oral SERDs, for example, that may better inhibit the ER pathway, and perhaps this will be an optimal way to think about combinations with HER2-directed agents. I think we also need to better understand the benefits of concurrent use of endocrine therapy and ADCs for metastatic disease, and work is ongoing exploring this. So what about overcoming intertumoral HER2 heterogeneity? We've learned that not all cells in a HER2-positive tumor are consistently HER2-positive. Sometimes there can be some cells within the tumor that are HER2-negative, as depicted in the red circles, amongst those HER2-positive cells depicted in the blue. So the concern would be that if you gave a HER2-targeted therapy, it'll only kill the HER2-positive cells but leave behind those HER2-negative cells. So there was a trial that specifically tried to address this question about HER2 heterogeneity, and this study was led by my colleagues Otto Metzger and Ian Kropp, and had looked at preoperative treatment with TDM1 and pertuzumab, and had obtained biopsies from all patients prior to going on to their preoperative regimen, and then looked at rates of HER2 heterogeneity at baseline and correlated this with rates of pathologic complete response after their HER2-directed treatment. Amongst the 164 patients in this trial, they found that 10% of patients did have heterogeneous HER2 expression. The majority of this occurred in patients who had hormone receptor positive tumors. And while the study found an overall PCR rate of around 50%, amongst the 16 patients who had HER2 heterogeneity, in fact, none of these patients achieved PCR, really supporting the concept that HER2-directed therapies alone will not be able to achieve PCR in the setting of HER2 heterogeneity. We've seen a similar concept of these results from the Christine study. This trial had randomized patients to receive chemotherapy with TCHP or to receive TDM1 and pertuzumab in the preoperative setting, and then after completion of surgery, they went on to their respective HER2-directed therapy with either HP or TDM1 pertuzumab. What we saw was that those patients in the TDM1 pertuzumab arm had higher rates of local regional progression prior to surgery than those getting TCHP. And this local regional progression was more common in those patients who had heterogeneous or low HER2 expressing tumors. Interestingly, data from the Catherine study, which had looked at substituting trastuzumab with TDM1 in patients who had failed to achieve PCR after HER2-directed therapy, had looked at HER2 status on the baseline core biopsy and correlated this with long-term outcomes, and did see that those patients who had 1+ and 2+ disease seemed to have a little bit less benefit compared to those patients with 3+ disease. So again, I think suggesting that higher HER2 expressors are deriving greater benefit from these HER2-targeted treatments. So another challenge that we have is with regards to HER2 low positive disease, which is different than HER2 heterogeneity. HER2 low positive breast cancer is defined as a tumor that's 1+ or 2+ staining by IHC, but not amplified by FISH. And using this definition, approximately half of all breast cancers are HER2 low positive, with a higher prevalence, about 2/3, in hormone receptor positive breast cancer, and a little bit lower in triple negative disease at about 25 to 30% prevalence. And while we've seen very minimal activity for monoclonal antibodies or TDM1 in HER2 low positive disease, there's suggestion that novel antibody drug conjugates have encouraging activity in this setting. Trastuzumab deruxtecan, or TDXD, is a HER2-targeted monoclonal antibody conjugated with a topoisomerase 1 payload through an enzymatically cleavable linker, and this agent has a very high drug-to-antibody ratio of about 8:1. And we've seen from a previously presented basket study that had 54 patients who had HER2 low positive breast cancer had received TDXD, that objective response rates were almost 40%, with a PFS of around 11 months. And this is certainly interesting, and interestingly also similar in terms of outcomes for HER2 2+ compared to 1+ disease. We also have some data to suggest that TDXD can even work in HER2 IHC 0 tumors. And these data come from the DAISY study, which had 3 different cohorts, one looking at TDXD in IHC 3+, another in IHC 1+ or 2+, and then finally a cohort for IHC 0. And you see activity in each cohort, and it ranges from about 70% response rate in IHC 3+ down to about 30% response rate in IHC 0. But I think this study really raises the important question about how we're testing for HER2 and how we're going to be able to better quantify HER2 expressing tumors. Because I think the challenge is the way that we currently test, where we've used HER2 as this categorical variable with different buckets for results. And even if you look at HER2 IHC0, the definition does allow for a little bit of faint staining in less than 10% of cells. So there still is a teeny bit of HER2 expression here. And I think it begs the question, can we quantify HER2 better as a continuous outcome to better select patients for these HER2 targeted strategies? However, these encouraging results have led to registration studies. So DESTINY-Breast04, which has completed enrollment, had randomized patients to receive T-DXd or treatment of physician's choice chemotherapy if they had received 1 to 2 prior lines of chemotherapy in the metastatic setting. This study had allowed for a small cohort of triple-negative breast cancer, but the majority of patients here were all hormone receptor positive. And then there's DESTINY-Breast06, which uniquely also has some HER2 IHC0 patients amongst the HER2 low patients, and instead is looking at patients directly after progression on endocrine therapy without any prior chemotherapy. So I think we're eagerly awaiting data to see if this can be a standard approach for our HER2 low patients. There are also other novel HER2 ADCs that are being explored, such as trastuzumab deocarmazine, which we have seen some activity in HER2 low positive disease, as well as RC48, which also has had some activity in HER2 low positive breast cancer. So in summary, I think the key takeaway here is that HER2 positive cancers are not all the same. As you can see, there are differences by hormone receptor status, where you can see differences in timing of recurrence, differences in rates of pathologic complete response, and differences in benefits from HER2-directed therapies by hormone receptor status. There are novel strategies that are being explored in this space, such as use of CDK4/6 inhibition, as well as oral SERDs. We also saw that HER2 heterogeneity can limit benefits to treatment, such as we saw with TDM1. But I think it also raises a question about whether T-DXd could potentially overcome this limitation by its ability to function by bystander effect. We also saw that HER2 low positive breast cancers can benefit from HER2-directed ADCs. I think it's important to realize that this is probably not a new biological subtype of disease, but rather is just a subset of tumors that have some HER2 expression and can use this expression to get targeted delivery of high levels of cytotoxic payload. But I think it does beg the question about how we're going to be able to move forward with quantifying HER2 to better select therapies for this subset of patients. Thank you so much.